Let's ultrasound. On today's edition of General Ultrasound, let's talk about what not to do. These are my pet peeves. Hi everyone, I'm Michelle McCauley, and I've been a sonographer for over 17 years. I'm also the head general scan lab instructor for one of the top ultrasound programs in the United States. So it's fair to say that I've seen a little bit of everything. Here are my top pet peeves, things you shouldn't do when taking ultrasound images. Number one is to leave what I call a floating caliper in an image. And you can see this in the top image to the right. There's just a random measurement caliper left in that image within the bladder above the uterus. And usually this occurs when you're using a calc package in the machine. This means that you're using the machine to store all the sets of measurements for an organ. So it's storing the length and the height and the width of the uterus in this specific example. When you freeze an image, the ultrasound machine automatically will bring up the next caliper for you to take the next image within your series of measurements. When this occurs, you can go ahead and take your measurement and then take the caliper off and then take your image without calipers. What I see a lot of people new to ultrasound do is when that caliper comes up, they automatically will take their image without calipers with that random caliper just floating in the image. And then they'll go on to measure. That floating caliper is considered an unprofessional image. My next pet peeve is when I see images that don't specify which kidney you're taking pictures of. Please don't annotate kidney on an ultrasound image, but forget to include whether it's the right or the left kidney. Yes, sometimes you can tell which kidney you're in. Obviously, if you see the liver, then you're in the right kidney. If you see the spleen, you're in the left kidney. However, sometimes when you're taking transverse images, you may not have the liver or the spleen in there. And people new to ultrasound imaging are notorious for flipping their transducer backwards. So you also can't necessarily use which way the kidney is pointing as a landmark to figure out what kidney you're imaging. So it's really crucial to always put right or left in addition to the word kidney so that the radiologist and also yourself, when you go back and look at your images, know exactly where you were in that moment of time. Another issue with this is that pathology could accidentally be interpreted as being in the opposite kidney. The next mistake that I see happening pretty frequently actually in people that are brand new to ultrasound imaging is measuring the endometrium as the uterus. And this most commonly occurs when you're in a transverse plane. So it's really crucial to study the echogenicity of the structures that you're measuring. When you're in a transverse, transabdominal imaging plane, you can clearly see that the uterus border is hypoechoic compared to the hyperechoic endometrium. So you want to ensure that you measure the outer borders of the uterus and not the endometrium as the uterus. The next faux pas is forgetting to take an image without calipers. And this, I think, might be one of my biggest pet peeves, especially when you're new to imaging. Sometimes your images aren't all that great, and that's okay because you're learning. But if the only image you take of a structure is an image that has calipers on it, it can be really hard to see the structure behind those calipers and determine what's going on with that structure, if anything. So I always tell my ultrasound students, I would rather you take an image without calipers than take an image with calipers if I had to pick. PACS systems today allow you to go back and add calipers later on after the fact. However, you don't have the option to take off calipers. And the goal of every ultrasound image is to tell a story. And if you're telling a story with an image that's covered up by calipers that you can't interpret anything from, then you only told half of the story. The next thing to watch out for when you're taking ultrasound images is what I like to call the pseudomass, and you can actually see this in the top image. This is an image taken of the kidney, and you can see the dark hypoechoic circle in the bottom portion of the kidney. This is not actually a true mass. The kidney was just taken at an angle in which that portion of the kidney looks darker. So you can see how that would catch a radiologist's eye, and this may be labeled as actual pathology when in fact it's just a pseudomass. So when taking ultrasound images, make sure you carefully inspect your entire area of interest and ensure that you're not hitting it at a funny angle and producing a pseudomass when it's a normal structure. The next pet peeve on the list is to not measure simple Nabothian cysts. Nabothian cysts are cysts that are in the cervical region. If these are simple and they're small, there's no debris in them, there's no vascularity in them, please, please, please do not measure these. And even worse, don't measure multiple of these. You will drive your radiologist crazy. And this is also a sign of someone that's very new to imaging that doesn't truly know what they're doing. So when you hit your clinicals, show them you know what you're doing. Don't make this mistake. The next mistake on the list is measurement calipers that are not perpendicular from one another. Whenever you need to place more than one caliper on an ultrasound image, those calipers must be exactly 90 degrees orthogonal or perpendicular to each other. Otherwise, you're measuring a dimension that's off axis. It's crucial that a length measurement is always going to be horizontal on the ultrasound image, and a height or anterior measurement is always going to be a vertical measurement on the ultrasound, and width is always going to be a horizontal measurement. So horizontal, vertical, horizontal. And whatever picture you take two measurements on, those calipers need to be exactly perpendicular. Another thing that I see people learning ultrasound struggling with is using the wrong machine preset. Ultrasound machine presets automatically optimize the machine settings for a specific exam. For instance, abdomen or OB or carotid. Using the wrong exam preset is going to cause you to have to do a lot more optimization to try to make your images look diagnostic. And no matter how much optimization you do, they're still going to be lower quality than if you had used the correct preset. So if you find you're really struggling to get high quality images, check your imaging preset and see what type of study you told the ultrasound machine you're going to be using. Often, you'll be trying to image the aorta under a pelvic setting or something like that, which will lead to you really struggling to obtain diagnostic images. The next ultrasound mistake is diagnosing via annotations, and you can see this in the top right image. They've measured a structure within the ovary and they're calling it a cyst. Don't do this. This might be the most obvious pathology in the world, but the second you start putting diagnoses on an ultrasound image, you open yourself up to being sued. If you think that you know what type of pathology you're dealing with, write that on your sonographer worksheet and let the radiologist make the formal diagnosis in their report. So there's 4 things that belong in ultrasound annotations. You want to put the patient position, you want to put the segment of the structure you're in, such as proximal or mid. You want to put the transducer orientation, such as sagittal or transverse. And then you also want to label your area of interest. If you can't see something when you're looking at a structure, I want you to annotate it with area of and then the name of the structure. For instance, let's say I'm imaging the pancreas and I can't see the pancreas. I would say area of pancreas. It's also permissible to use annotations to establish relationships. Example, let's say you have a mass that's next to the right ovary. It's acceptable to label the right ovary to show the right ovary's relationship to the mass that's next to it. However, don't annotate mass on the images. Leave the mass blank with no annotations on it. This will help establish where the ovary is in relation to the extra structure that shouldn't be there. When you need to measure multiple masses, let's take the thyroid as an example. You can say mass 1, mass 2. Don't use the word mass, however. Use sonographer shorthand. So M1, M2, and place this M1 and M2 up by all the other text on the image. Don't place it down next to the mass. It is permissible, however, at the end of your study, after going through and measuring everything, to take an image, let's say of the thyroid, where you can take one image that shows M1 and M2 labeled right on the masses, and this is going back to showing the relationship of things to one another in an image. However, it's crucial that you have taken your series of measurements and color Doppler and all your standard ultrasound images of that area without that labeling on top of it. And I want you to be really careful when you're using annotations as a sonographer. Always think, can this annotation get me in legal trouble? Because sonographers do get dragged into court. So everything that you do is creating a permanent record in that patient's file. So always think in the back of your mind, could this get me in legal trouble? And err on the side of caution. Okay, this next one is an absolute no-no, and we call this sloppy sonography. And this is taking a measurement of a structure over the top of colored Doppler information. No, just no. Please do not do this. This can not only obscure the color Doppler information, but the radiologist cannot tell if you're accurately placing that caliper. You want to take the color Doppler off before you measure. And for every structure that you are taking images of, I want you to take 3 images. A grayscale image without measurements, a grayscale image with measurements, and then a color Doppler image. Get in the habit of performing them in this order, and you will not learn bad habits, which will cause you to forget one or more of these 3 images, or to resort to sloppy sonography, such as measuring over the top of color Doppler pictures. The next thing not to do is to take a blurry image. So what causes a blurry image? There's really 3 things. Number 1 is having an over-zoomed image, especially if you're using read zoom. This is the type of zoom that's used as a post-processing function after the ultrasound machine image is frozen. This type of zoom can end up blurry really fast. The next thing is capturing a blurry frame when you're using CineLoop. If you freeze an image and scroll back through the frames to choose a better frame for your image, make sure you're not picking one that's blurry. And the third thing is freezing an ultrasound image while you're imaging a moving patient, and the image that you freeze on the screen happens to end up blurry due to patient motion. If this happens, use your CineLoop control to scroll back and pick a frame that's not blurry. Before storing any image to the hard drive, evaluate the image to determine if it's blurry. A blurry image is a non-diagnostic image. You want to remove the cause of the blurry image. So either decrease the amount of zoom or use a different frame of the CineLoop before you store the image. The next mistake is forgetting to sweep through an organ. Sweeping is the most important job of a sonographer. We are not picture takers. We are the eyes of the radiologist. Taking a beautiful image of something like the liver and measuring it does no good if we didn't sweep and we missed a mass or other pathology in that liver. If all the images that we took of that liver don't happen to capture that mass in any of them, we've just missed pathology. Sweep, sweep, sweep. Only then, after you've swept, take images. The next really big don't do this is taking an image with a shadow down the center of the area of interest. Nope, no, absolutely not. This is sloppy sonography at its very heart. Before taking an image with a shadow down the center of it, ask yourself, how much of this image is actually diagnostic? And the answer is usually not much. So don't do it. This is a non-diagnostic image, and it's going to end up being deleted by the radiologist. Find a different window. Use breath holding techniques. Roll the patient into a different position. There's always a better window than obtaining an image with a shadow down the center of the area of interest. Now, there are times when there has to be a shadow, although this should be rare. If you have to have a shadow, it's better it's at the edge of the area of interest than down the center. If an image is taken with a shadow at the edge of an area of interest, then make sure you take a second image from a different window that captures that missing portion of the area of interest. I'm just going to title this next slide, No Diving Kidneys. Absolutely not. This is what separates a sloppy sonographer from a great sonographer. So ask yourself, which one do you want to get known as? And don't forget that kidneys can dive more than one direction. So either the superior pole can be at the bottom or the inferior pole at the bottom. Either way, these are both diving kidneys. A diving kidney means that that kidney is vertical on the image. Don't do this. You want to roll the patient, use a different window to make the kidney more horizontal. The further medial you are in that patient's body, the more diving that kidney is going to be. So you want to go lateral towards the outer portions of the patient's body to make the kidney horizontal on the image. Now, however, when we're imaging the transverse kidney, you want to do the opposite. You want to move more medially to use the liver and the spleen as a scanning window. So lateral for sagittal kidneys, more medial for transverse kidneys. Now, why would it matter if a kidney is diving on the image? This has to do with image resolution. GRAYSCALE loves horizontal structures. This ensures that we can use that focal zone control, narrow the ultrasound beam over the entire area of interest. If one end of our structure is way down low on the image compared to the other, where are we going to put our focal zone? That focal zone is only going to be able to narrow the ultrasound beam and focus on a portion of our area of interest. So not only are we trying to improve lateral resolution, but we want to be seen as a skilled sonographer, and that we're not a sloppy sonographer. We're taking the time to take not only diagnostic images, but high quality diagnostic images. Another really common mistake that I see often is forgetting that grayscale images and Doppler images have very different requirements to them. When we're taking Doppler images, we want our structures to be more vertical on the screen. And the reason for that is Doppler likes vertical structures. However, when we're taking grayscale images, we want exactly the opposite. Grayscale images are best when the area of interest is horizontal on the ultrasound image, perpendicular to the ultrasound beam. This not only improves lateral resolution, but it also helps us optimize depth. One side is not deeper than the other, so it allows you to have less depth and your image closer on the screen. And it allows us to improve that lateral resolution, using the focal zone to narrow the beam throughout the entire area of interest, not just at one end of it. So if you remember nothing else from this talk, remember grayscale likes horizontal structures, Doppler likes vertical structures, and Doppler likes angles. The best angle for Doppler is 0 degrees. However, that can be hard to obtain. So any degree that you can achieve between 0 and 60 degrees makes Doppler happy. However, when you have a horizontal structure on an image and you're using Doppler, this means that your area of interest is perpendicular to the ultrasound beam. No Doppler shift is going to be happening at that 90-degree angle when the vessel and the transducer are perpendicular. Now, how do we make structures horizontal versus vertical? One method is by heel toeing the transducer, pressing on either the top or the bottom of the transducer to create an angle or to make something more horizontal on the image. The other way is by using a different scanning window. For instance, when we're imaging the kidneys, moving more laterally in the body makes the kidneys lie more horizontal on the ultrasound image. My next pet peeve is missing images or images out of order. Get into the habit of filming every protocol you do in a certain order and then stick to that order for every single exam. This is going to help ensure that you don't forget any images along the way because it's going to become second nature. That way, when you come across pathology, you'll have it so ingrained in you what pictures to take, you won't get distracted by the pathology and forget to take images. Also, take a grayscale image without calipers first, then a grayscale image with calipers, and last a color Doppler image. These 3 images in order every time. This is also going to build a habit so that images without calipers or without color Doppler are not missed. Practice becomes habit, habits become ingrained. The next mistake is taking images that are too zoomed. I like to call this over-zoomed. When images have too much zoom applied to them, they can become blurry with ill-defined edges, or they may become so large that they are cut off on the bottom of the image. This is insufficient depth, or on the sides, meaning your field of view is too small. So not only may you be cutting important information out of the image, you also most likely are going to have a blurry image. Now, one thing to keep in mind is a radiologist from their end can zoom an image, but they cannot take away zoom. So you may need to go back and refilm images if your images are too zoomed up. Also, over zooming an image can cause you to be in the wrong segment of an area of interest. So let's use the proximal aorta as an example. If you over zoom an image of the proximal aorta, it means you can no longer see the liver and the SMA well. So you may be mistakenly in the mid aorta instead of the proximal. So you could label pathology in the wrong segment of the aorta, or you could think that you've imaged all segments of the aorta when you really haven't. So it's crucial to apply the correct amount of zoom to an image if you're going to use the zoom control. We've now made it to my biggest pet peeve, and I'm going to call that over-gained images. Please, pretty please, pay attention to your gain level. The number one mistake that people new to ultrasound make is that the gain level is set too bright. We call these sunglasses images because you need shades to look at them. They hurt your eyes. When you are first starting out in ultrasound, usually the gain needs to be set much darker than you think it does. The gain should be set in abdominal imaging so that most soft tissue organs, such as the liver and the spleen, are a slightly dark version of medium gray. If you have a hyperechoic liver, then you either are going to have a patient that has a really fatty liver, or your gain is set way too bright. So questions to ask yourself: could you see a hyperechoic mass in your area of interest? Could you see a hypoechoic mass in your area of interest? If the answer to either of these questions is no, then your gain level is off and you need to do some adjustments. Now let's look at the images to the right. The top image, the gain is too bright. And this is a common image for people new to ultrasound to take, and they think that this is a quality image. However, if you carefully study that image, you could see that it'd be really hard to see a hyperechoic mass in that image. The image on the bottom is the correct gain level. And when you're first starting out, this seems too dark. Everyone's afraid to go too dark. But what I can tell you from 17 years of experience is better to have an image that's a little bit too dark than one that's too bright. So err on the side of darkness.